Good afternoon. I'm the last speaker of an excellent session. And ideally, probably this talk should have been the first talk because technologically, everybody else was so much advanced talking about apps. So I don't know how apt my talk is going to be at this point of time. But incidentally, I tend to work in two different places. One is a government hospital. And in the evenings, I have the privilege of working in a corporate hospital where I can use everything else that was discussed until now. And since I'm the last speaker, I think I'll have the privilege of overshooting time. And I'm going to talk about SMBG Diaries. And essentially, in the government hospital where I work, I run a clinic for kids with diabetes who come from underprivileged areas. This is actually a day when they were celebrating all well dressed up. Actually, they are not that well dressed up. And I keep a diary in the clinic for myself as well as my residents to write down what they've learned this week. So everything that I will show you is actually what I have seen in my clinical practice, what me and my residents have actually written down over a period of time, and I shall share with you. There's going to be very little theory involved, no pharma involvement, basic stuff that you see in day-to-day clinical practice. And it will start from very simple things to relatively more complicated stuff. So the first child is a 14-year-old girl, type 1 diabetes, since the age of 12, was on premixed insulin because that's all that their parents could actually afford at that point of time, and was relatively well controlled according to the patients that are actually coming into government hospitals with an average A1Cs of 11.5 and 12 in type 1 diabetes. No severe hypos, and this is what the blood glucose are. Suddenly after the 12th, you can see there is a big rise in blood glucose. And on history, you see that she's not feeling well, febrile, dysuria, nausea, vomiting, not eating. So we admitted the child, diagnosed UTI, treated with fluids, insulin, and antibiotics. The child recovered. So that's a very simple scenario where you see any intercurrent illness, the child's blood glucose will go up. And we were talking about DKA. So one small mnemonic that we tend to teach our patients with regards to DKA is a sick day rule. And just remember the alphabets of the word sick. S is for checking the sugars, I is for giving insulin, C is for the carbohydrates and fluid, and K is to check the ketones. So intercurrent illness will worsen glycemic control. The second is a 16-year-old girl with type 1 diabetes on basal bolus insulin, good to fair blood glucose control. Like many of our type 1 kids, they have other autoimmune disorders like juvenile rheumatoid arthritis in this child, has pain and swelling and redness in the knee joint off and on. And this is the child's blood glucose readings. Anybody wants to take a guess of what's happening? So I'll try and give you hints. Say, for example, look at 26th of January. The readings are relatively lower. 27th, slightly higher. 26th, 28th, again a little lower, and 29th, slightly higher. This child was on alternate day steroid therapy. So giving the steroids on the day of the therapy, the blood glucose is rising slightly, and on the days that he's not taking the steroids, it's slightly lower. So drugs like steroids might worsen glycemic control. Coming to the next patient, this is a 14-year-old on basal bolus insulin. And as you can see, the fasting glucose values goes on changing on a daily basis. Not uncommon in type 1 diabetes, this can well be normal. But what else do you think of when you see such variability? Now, what we often tend to forget is what's the time of doing the blood glucose test. The days that the child goes to school, the child wakes up early, does the blood sugar at 6 a.m., the days that the child is not going to school, is staying home, sleeping until late, and checking the fasting glucose at 10 a.m. So you are thinking that this child is having differences in fasting glucose because of certain reasons, but the main reason here is the timing of the fasting glucose test that you're doing. The next, if you see here, anybody would like to make any comments, just look at the dates. I know you are not from Bengal, but in Bengal, in October, there is Durga Puja. So in September, the blood glucose were relatively good. Now in Durga Puja, everything goes haywire. So, and there's another child who comes, nothing written on the logbook because the child has suspended monitoring altogether. So feasting and fasting and any change of lifestyle is going to lead to dramatic changes in the SMBG readings. The next is a 16-year-old girl, reasonably well controlled, very well compliant. Actually, she helped us to teach some of the other kids as well. And now you suddenly see that the blood glucose have started going up. There were even more other readings as well. But if you see the morning time readings, she's having hypoglycemia. Any possibilities? Now, this is a Muslim girl. I didn't even have any idea or clue to know that she's actually got married about 3 months ago. She's 16 years of age. She's pregnant. So early part of pregnancy, you can have hypoglycemia. There are pathophysiological explanations for the same. And if you look at glucose profiles through pregnancy, there is variability of insulin resistance and glucose utilization, which leads to variability in glucose levels all through pregnancy. This unfortunate girl actually came back to us with several problems, and I'm going to talk to her about 4 or 5 different scenarios that this same girl came back to us with. So she turns up at around 24 weeks. We've gone on increasing the insulin, and yet her blood glucose levels are high. So essentially, she's a type 1 diabetic, but because now the placenta is producing so much of other counter-regulatory hormones, she's behaving like a double diabetes, a type 2 diabetes, on a background of type 1 diabetes. So any intercurrent illness could be the cause, but here, essentially, it's the placental hormones which are pushing up the glucose readings all through the pregnancy. The girl does reasonably well and is adjusted, but then comes back to us at about 32 weeks. Now, again, she's now having hypos. So what could be the reason? Anyone in the audience wants to volunteer? So the commonest thing that you think when things go wrong in pregnancy in terms of the glucose readings going down is fetoplacental insufficiency. So the placenta has now started producing less of those counter-regulatory hormones, and therefore on the same dose of insulin, she's having hypoglycemia. So it should be a warning sign to you that things are not right. You should bring the patient back, admit the patient perhaps, let the gynecologist and the obstetrician have a look at the patient and decide. So she gets admitted, and then the next evening, my resident gives me a call saying her blood glucoses are now again through the roof. Now, what could have gone wrong? Very common scenario, the doctor has given her betamethasone. So the betamethasone after the admission has pushed up the blood glucose values. So at that point of time, you would probably have to escalate the dose by about 20 to 40%, and you know that after the expulsion of the placenta, the insulin requirement will again go down. So that's what happened. So 2 months later, she comes back to the clinic again with hypos. The first thing that I think is she pregnant again? Right. Fortunately, she isn't. So what could have happened now? Anybody, any guesses? She's a type 1 diabetic. So she's got a background of autoimmune disease. She's developed a postpartum thyroiditis. Poor girl, gone through so much of trouble in a year's time or so. So postpartum thyroiditis in type 1 diabetes is not uncommon. I'm not going to go into the pathophysiology for paucity of time because I still have a couple of more cases to at least show you. So again, this is a 6.5-year-old girl who's had reasonable blood glucose, checks blood sugars once a day, but on the Friday, faints in the playground requiring admission. One of the teachers had actually not turned up, so they had a protracted lunch break, and the child went on playing. So increased physical activity of any sort is going to reduce your blood glucose values, something that you and I need to be aware of. Now, this is a 12-year-old girl. So if you see until, say, the 13th, she was doing pretty well. But then suddenly, from the 14th and the 15th, the blood glucose has gone up again. So the first thing that you think of is whether she's taking the insulin, whether there is any infection or otherwise. But there's something else that we often forget to ask. Has there been any change of the insulin? Or has there been any change to the insulin syringe that you are using? So in India, we have 2 different kinds of insulin syringes, the 40 IU and the 100 IU. So now she's taking the same insulin with a 100 IU syringe, which has resulted in 2.5 times reduction in the dose of the insulin, as a result of which her blood glucose levels have actually gone up. The next is a 17-year-old who's come to our clinic for the first time, whose fasting glucose is all over the place. Now you might say, did you check whether they were checking at the same time of the day? Incidentally, he was. But he was injecting it wrongly. He was injecting insulin intradermally. So you don't assume what has been taught to the child previously. You've got to figure out, was the technique of insulin injection taught properly? Did you check for lipoatrophy? Did you check for lipohypertrophy? And we've published several case reports where you can see things can go wrong in terms of lipoatrophy and wrong sides. The previous speaker was talking about lipoatrophy and hypertrophy. We actually published an entire series after this particular publication where you might have lipoatrophy and lipohypertrophy even in the same patients. So that's something. Every time look at the insulin injection site before you think of variability and the causes of variability. Now, like I said, a significant proportion of those kids coming to my government hospital, many of them don't even know how to read. Their parents don't even know how to read. Maybe somebody else is writing down their SMBG logs. So it's not surprising that I've had someone who's actually written this down. That's the code of the glucometer. You see that? That's exactly what has been written there. And I've had even people who've actually written down 888. That's the number which comes up before the calibration of the meter. So we actually wrote an article to try and say, what should we be wanting from a glucometer? And a lot of that is already there. Why not have a glucometer which will give you the readings in your own language? Technology is there, use it. Why not have a talking glucometer for people who can't read? We don't need red, greens, and yellows. It can just say it out. Your smartphone has so many languages. So actually that's there now. I could have probably gone and done another talk on glucometers. So moving on to another child. A 12-year-old girl, type 1, goes on a school trip. Actually, this is the first time she's going out where the parents are not there. She's on a split mix regime of actrapid and insulatard, and this is her blood glucose charts. Can anybody tell me what might have gone wrong? So if you see, the 12th and the 13th, she was at home. Now on the 13th evening, she's gone out on that school trip. The 14th is when she's done her blood glucose, and the 15th. So if you look at her pre-meal readings are lowish and her post-meal readings are high. What could have happened? So she's on a split mix. So you first draw the actrapid, and then you draw the insulatard, and then you inject yourself. So look what's happened to her bottle of human actrapid. It's all cloudy because the actrapid has gone into the insulatard has gone into the actrapid and converted the short-acting insulin into a long-acting insulin, and therefore the post-meals are high and the pre-meals are low. This is another child, pretty weird. If you see, her HbA1c is 12, but all her blood glucose readings are good. So you might say, things have been great of late, but not that great in the past, and therefore that's the blood glucose reading like. So what I've learned is, and we actually published an entire series in IJEM, I'm not going to show you that paper, that never ever trust an SMBG chart. Always cross-check with what's written there in the glucometer. So there's selective amnesia. Every time you see the higher readings, you don't write it down. It's only the good readings that you write down. The child does it because the child is worried that the mother might scold the child. And if it's the mom who's actually writing it down, the mom is scared that the dad is going to come back home and scream at the mom if their glucose readings are high. It's unfortunate reality. So you can see other fabrications there. The child is too naive, has actually written down numbers all ending with zeros because she's not that intelligent, to fudge things. But that's how it's been written. And then there are others who've actually written down things in a particular pattern. Now coming to the story of a very intelligent girl. Her mother is a doctor. Her aunt is a doctor, is a colleague of mine, incidentally. And therefore, you tend to trust more than what you would normally have done. This has happened only the last month. 14-year-old girl, type 1 diabetes, diagnosed 5 years ago, has been admitted 4 times with DKA in the last 1.5 years. Entirely unexplained until after the story that you hear, you will know. and has said, I've had to cut down my glargine to almost zero 0.5 units. So now I didn't believe that this is probably going to be right, and that she's going on having hypos for the last 2 weeks. So we thought we would admit the child to see what exactly is going on. So on the morning the child gets admitted, the child has a hypo. So we take blood samples of the child to see that the C-peptide indeed is undetectable almost, but the insulin levels are high. So essentially, the girl is self-injecting herself with insulin so that she has recurrent hypos, so that she doesn't have to go to school, so that she doesn't have to appear in the exams. And in terms of the DKA as well, the child was not taking insulin every time before her exam, so that she gets admitted. She had got admitted with a pH of 6.9 and with a bicarb of 1 the last time. And if you see, in hospital, we took away everything from her, and we started monitoring. That's when she had that hypo, when we actually measured things. And we saw, once we stopped things, 0.5 units of glargine was not at all enough. And the blood glucose went on increasing. Ketones started coming positive. And that's when we started infusion, and then again went back to basal bolus. So the real cause here in this individual is psychological. So we are still struggling with this girl. Hopefully we'll be able to get things better. Sorry, right. So as I was saying, so glycemic variability can be because of infections, can be because of steroids and other drugs. It could be because of onset of puberty, pregnancy, missed doses, teenage tantrums, situational, feasting, fasting, festivals, public embarrassment, inconvenience of carrying insulin. Someone might run out of insulin. There might be problems with storage of insulin. There might be skipping of diet. There might be a lot of unforeseen, unaccustomed exercise, problems with syringes, injections, techniques, glucometers, fabrications, and psychological problems. I will finish with one last case. This particular individual was referred to me by the ITU consultant. Patient has been admitted with recurrent episodes of loss of consciousness several times in the last 1 week or so. Every time he recovers, he goes home. He's a 57-year-old businessman, known chronic kidney disease, is on peritoneal dialysis at home, and has symptoms of hypoglycemia, but every time he checks his blood glucose, either at home or in the hospital, the CBG is absolutely normal. So any guesses, anyone? Right. So just a little bit about background about glucometers. The glucometers work on certain principles. So it could be with the hexokinase system that it works, or it can be with the glucose oxidase system that it works. And most of the machines that we use work with the glucose dehydrogenase system. And there are several things that are important for the glucometer to work correctly. And one of those principles with this glucose dehydrogenase method is ability to have or detect reducing substances in the blood drop that you are checking. And there are several things which interfere with that, including icodextrin. That essentially contains stuff like maltose. Now, maltose essentially is glucose plus glucose. So this individual who's on peritoneal dialysis is actually having true hypoglycemia. The peritoneal dialysate contains icodextrin, which contains maltose, which falsely elevates blood glucose readings on the CBG. So when you're checking your glucose with the glucometer, you find that the blood glucose is 110, 120, when actually the blood glucose of this individual is much lower. So there is overestimation in patients with peritoneal dialysis. So you will know you need to know which glucometer works with which system. Here we were using the AccuCheck, which has a significant interference in patients who undergo hemodialysis, peritoneal dialysis. The peritoneal dialysate actually interferes. There are certain other drugs which also might actually cause similar problems. I think I've still managed to finish on time. Thank you very much for your patient hearing.